Hello, welcome to our meeting. We'll be talking about high power ablation in patient with atrial fibrillation. So let me begin. I try to answer 4 questions. First of all, could our radiofrequency ablation be shorter than cryoballoon ablation in AF patients? Could our application be less painful, especially in sedated but still alert patients? How to minimize the injury of esophagus? And what extra information you can get from voltage map and how they can be useful for us. But before we move to main topics, I want to show you my workflow. So first of all, I performed transeptal puncture directly with Agilis steerable sheath. I've been using this approach for years now, and it's very, very rare that I have to switch back to non-steerable sheath and afterwards change it to Agilis again. So generally the time from the first needle puncture till the cannulation of left atrium is about 15, but generally less than 20 minutes. My next step is voltage mapping, as I always go for additional substrate ablation apart from pulmonary vein isolation in each of my AF patient. I want to know, apart from anatomical information, I want to know to have data on possible substrate to be ablated. So depending on the size of left atrium and that possible substrate, mapping takes me about 10-15 and in rare cases even up to 20 minutes. After switching the catheters, I start ablation with tacticath using 50 volts. The time of my application is limited by LSI. So generally the time to full pulmonary vein isolation is about 10-15, sometimes 20 minutes. In case of any additional substrate within left atrium, I go for the substrate as well. So sometimes I perform substrate isolation, sometimes I just perform homogenization of this area. And times varies, so it's difficult to say how much time it takes to finish the full substrate ablation. As I mentioned, I use tacticath catheter, which is commercially available for all of us. My power setting is 50 volts, so it's maximum allowed power setting by manufacturer. So if you want to go above 50 volts on tacticath, you will probably need the agreement of your ethical committee. As you know, during our radiofrequency applications, we have 2 phases, resistive and conductive heating. So as I would call this primary phase of resistive heating, very elegant and very operator related and dependent. We don't really know how deeply and how widely is the tissue being destroyed during this passive conducting heating. So when we restrict the time of our application to resistive heating phase only, and additionally we use higher than standard power settings, the lesions will be wider and shallower. The depth of our high power lesions will be between 2 and 4 millimeters. So they will be still deep enough to reach the transmolarity within a left atrium wall. And And additionally, when you remap the region of your ablation performed with a high power, you will see that it's more elegant than the ablation lines done with a standard approach. That's because you don't see this low voltage area. They are much narrower. Sometimes even they are not observed anymore. It's the result of resisting heating phase only. We don't produce any extra possible substrate for future arrhythmia. We don't have these low voltage areas on our ablation line, as happened when with the prolonged standard application, this conductive heating phase, which is not completely predictable by the operator, produces sometimes this low voltage areas. So when you have a good contact between your catheter and the tissue, it takes just few seconds to reach desired LSI. As you see, sometimes it's even so fast that the system it's not fast enough to mark the ablation point. Generally, ablating with 50 volts, you want to be between 10, 20, 25 grams with your contact force. You don't want to cross 30 grams. You may further shorten the application time with power generating settings. So when you set ramp up time to its minimum of 2 seconds and set autoflow as shown, you will further shorten the application time. On the right panels, you may observe the difference. So in right upper panel, you have the application with 50 volts, but with standard generator settings, and on right lower panel, you see much shorter application with let's say upgraded settings. So let's move to our first question. Could radiofrequency ablation be shorter than cryoballoon ablation? If we have a patient with a small or normal sized left atrium and we go for pulmonary vein isolation only, the needle to needle time would be about 1 hour or even less with 50 volts ablation. On the other hand, if we have patient with enlarged left atrium and we go for additional substrate ablation, my needle to needle time is longer. It's about 1.5 hour. But if you skip mapping, which I perform, voltage mapping, the needle to needle time would be even shorter. Still, there are other factors which influence the time of our procedures. So the size of pulmonary veins, the distance between the veins, as I mentioned, time of voltage mapping. In some cases you will need to remap left atrium if during the ablation any other arrhythmia appears. You could go for ablation this arrhythmia as well. Of course, the catheter stability is crucial for each application, and if the catheter is not stable enough, you will fight to have good contact stability and to have proper application, so it takes time as well. And as I mentioned, I perform ablation in sedated but alert patients, so the communication with my patient is crucial. But if you ablate in completely sedated patient, your procedure could be faster. So let me present now a few clinical examples. The first patient is 61 years old, male with a history of persistent atrial fibrillation with good ejection fraction and normal size left atrium. As you see, the voltage mapping show that generally the left atrium is electrically healthy. So the plan in this patient was to isolate pulmonary veins only. As you see, time to left atrium cannulation was 16 minutes. Next 9 minutes took me voltage mapping and complete isolation of all pulmonary veins with additional application in left carina were 14 minutes. So needle to needle time was 49 minutes. So as you see, the time is quite comparable to the time you would get with cryoballoon ablation. But here I have additional information about left atrium, and I know that I am more precise with my applications. Next case is a 47 years female patient with a history of persistent AFib as well, a good ejection fraction, and again quite normal size left atrium. During isolation of left common trunk, we had induction of atrial fibrillation, and even after we completed pulmonary vein isolation, she was still in atrial fibrillation. We gave her intravenous drugs, but it didn't stop. As she was 74, I decided that I'm not very eager to perform next ablation in the future in her. So we decided to go for posterior wall. You know, the idea that the posterior wall is treated by many electrophysiologists, like prolongation of pulmonary veins. So that's what we decided to do, to perform box ablation of posterior wall. And during this isolation of posterior wall, as you see, the atrial fibrillation regulated to more regular rhythm, and then we have sinus error. And even though we had to perform box ablation of posterior wall, as you see, the needle to needle time was still less than 1 hour. Isolation of pulmonary veins took me about 11 minutes, and additional application on posterior wall to have the complete box isolation took about 1.5 minutes. And again, you have your applications precisely where you want them, and the time is still comparable with cryoballoon time. Next case is a fairly young patient in whom I perform ablation of long-standing persistent atrial fibrillation in 2015, and he was in sinus rhythm for over 5 years, but since 2020 he started to develop atrial tachycardia. And this left atrial tachycardia became incessant since the end of 2020. After we perform our propagation and activation map, we identified the region of arrhythmia in mitral isthmus, and as you see, during the third application, arrhythmia was gone, and we have sinus rhythm. So the needle to needle time at this point was 33 minutes, and that's the point at which some of us would finish the procedure, but we went further. I perform additional application in mitral isthmus and additionally clean up the region of anterior wall line performed in 2015, just to be sure that it won't be the region of future arrhythmia. Nevertheless, the needle to needle time of the whole procedure was 46 minutes. So as you see, even in patient with left atrial tachycardia, we can be in quite a reasonable time with our procedures. The next case is a 75 female patient with long-standing persistent atrial fibrillation, impaired ejection fraction of 29% and enlarged left atrium. We try cardiovascular in her, but none of them was successful, so we couldn't restore sinus rhythm with cardiovascular in her. And as you see, voltage mapping shows from electrical point of view just a disaster in left atrium. As you may expect, pulmonary vein isolation didn't help. So we went further with our ablation and performed a full isolation of left atrium. What I did is I performed arterial line from right superior pulmonary vein down to mitral valve, then a line in mitral isthmus and additional box ablation of posterior wall. So the whole left atrium was isolated apart from interatrial septum and inferior wall. And as you see, during closing the box on posterior wall, we have a return of sinus rhythm. And despite of extension ablation, the needle to needle time was 78 minutes. Next patient with recurrent atrial fibrillation was operated by cardiac surgeons, and during implantation of mitral valve, he had also ablation of atrial fibrillation done by surgeons. But the result you see yourselves. Voltage mapping in this patient took me more than 20 minutes, as you see. But time to clean up all these low voltage areas and in the result to isolate left atrium was less than 10 minutes. And the total needle to needle time was 72 minutes. So it's still a quite reasonable time for such a procedure where you precisely have to clean up all these low voltage areas. And it couldn't be done with cryoablation at all. And final example of a 52 years female patient with a history of paroxysmal atrial fibrillation after cryoballoon ablation with 28 millimeters balloon in fairly small left atrium, 37 millimeters. So you see the result of cryoballoon is such a small atrium, large regions of scar and low voltage areas. Now she's been having recurrent atrial fibrillation and atrial tachycardia, very badly tolerated. So yeah, I had to clean up all these low voltage areas. It took about 10 minutes and we finished with sinus rhythm, and the whole needle to needle time was about 1 hour. You see that even with extended ablation, our times using high power application are quite reasonable now. So the answer to our first question would be positive. In about 1 hour we are able to perform quite detailed substrate mapping, perform pulmonary vein isolation, sometimes even with additional substrate ablation. Our applications are precise, and I believe that we are less pro-arrhythmic with high power. Let's move to our next two questions. Could radiofrequency application be less painful, and how to minimize the injury of the esophagus? As these two questions and answer to these questions are related, I will try to answer them both in the same time. As you ablate in completely sedated patients, you probably use esophageal probe to measure the temperature during applications. In my case, I perform ablation in sedated but fully alert patients. So my patients feel the pain, and sometimes they say stop to my application. So I have to cease the application because of the pain felt by the patient. It mostly happened on posterior wall, which is quite understandable. But from the first ablation with high power, I started to observe that the number of stopped application due to pain felt by a patient drastically increased. So simply just by switching to high power, the procedure became less painful for alert patient. By further shortening of application time with our new generator settings, we further decrease the number of stopped application due to pain felt by a patient. But real advantage and increased safety related to ablations performed on posterior wall is related to something which I called jumping technique. As you may observe my first application points on posterior wall, you see that I'm leaving gaps. I'm leaving the gaps for purpose, and I'll be closing the gaps with the next round. As you know, there's a portion of fatty tissue between epicardium and esophagus on posterior wall, and cooling down of myocardial tissue is much faster because it's cooled down by constant blood flow within the left atrium. The time of cooling down of fatty tissue is much slower. The fatty tissue keeps the heat much longer. So when you ablating point by point, creating the line point by point with its continuity, it could happen that you overheat the region and you overheat the esophagus. By leaving the time for the fatty tissue to cool down, so by leaving these gaps, you will give the time to cool down for the region, and your next application will be safer in this region. Additionally, what we noticed in our alert patients, such approach is less painful. So we have additional proof that from clinical point of view, our application are less painful, so most probably less prone to esophageal injury. On the other hand, there is a nice publication from last year by a Canadian group which measured the temperature in esophagus, and they show that you have to wait sometimes even 60 seconds for the temperature to return to its basic value. So you see how important it is, especially on posterior wall, not to overheat this region. And with this jumping technique, you can reach it. What additionally was shown in this publication of Canadian colleagues was that in patients with higher BMI, so in fatty patients, the time of cooling down was even more prolonged. So we can assume, and that's my explanation of this finding, that the more fatty tissue, the longer should be the time for cooling down the region of the application. So I've been using this champing technique for 2 years now, and with this approach, the number of stopped application lowered almost down to null. So, answering our two questions about pain felt by the patient during applications and esophageal injury, I feel that even switching to high power ablation itself, it's safer. And with additional generator settings and this new champing technique, you will further increase the safety of your procedure. And in alert patients, you won't have any application stopped as a reason of pain felt by a patient. And the final question about cutoffs of the voltage map. So I show you how to use extra information from voltage mapping. Generally, when we think about cutoffs of voltage map, we think about lower cutoffs. So we want to see the electrically healthy myocardial, and this cutoff is set by most of us at 0.5 millivolt. To show the scar, we classically set the voltage lower cutoff at 0.2 millivolts, but now we are more prone to go even lower, down to 0.1 millivolts, and if you use HD grid, you will lower this limit even further, down to 0.05 millivolt. So if you want to see more within the scar region, you will have to lower the lower limit. But what about upper limit set at half millivolt? Could we get any extra information by changing the upper limit? On right panel, you have the voltage mapping of left atrium. By moving the upper cutoff up and up till the almost disappearance of violet color, we identify the regions of highest amplitude within left atrium. And the region of highest amplitude should be related in a healthy atrium to the radius of highest thickness of the atrium. So you would assume that the region of with higher amplitude are region of some kind of hypertrophy, or the region of increased thickness, and you most often will observe this highest amplitude region on interatrial septum, in left atrial ridge, and in the region of Bachmann bundle in the roof. But why you need these informations? Despite the fact that I'm trying to show you the advantages of high power ablation, I think it's not the final solution. As I showed you at the beginning, the lesion done by high power ablation is wider but shallower than the standard application. So it could happen that in very hypertrophed or very thick regions, our high power application won't be transmural, and we would go back to a standard approach and just burn with our radiofrequency ablation longer to use conductive heating. what I've been observing in patients with recurrence of arrhythmia, which were done with high power, I observed that if there were any gaps in my lines, they were mostly in the region of higher amplitude. That means in the region of higher thickness within left atrium. So at the moment I'm just trying different approach. I'm generally ablating with high power, but in the region of really high amplitude. I'm overheating with high power, by prolonging the application time. But in different patients, I'm trying to use standard power settings. And the time will show which will be the final and best solution. You may also change the cutoff value during the ablation procedure. As you see on the right panel, I'm doing it during the ablation on a lateral wall, just in front of left pulmonary veins. And you see that in fact my line goes through the highest amplitude regions. So if your patient is in sinus rhythm, you may additionally use pace and ablate technique. So during pacing, you observe when there is no capture. And if you cross your desired LSI, you are done. And you will also notice that in some region of higher amplitude, you will have to reach higher LSI that you primarily desired. But the main drawback of this technique is that you may use it in electrically healthy atria. If you have lots of low voltage areas and you will start to change the upper cutoffs, I don't know what kind of result you will get. And other group of patients, in which MAP was performed during arrhythmia, you have completely unreliable data. So if you want to change cutoffs, use it only in patient with in sinus rhythm. Concluding, let me say that I'm quite satisfied with this technique. The procedure is quite fast. I have lower number of redos, and with more than over 500 patients done with 50 volts, the complication rate is also quite low. So as you see on this graph, my technique changed over years, but still the main approach, 50 volts, stays the same. So I really encourage you to try yourself 50 volts, and you will see how fast you can be.